Welcome, everyone. We will get started in just 1 minute. We are just going to allow for a few more people to trickle in, and then we will begin. Thank you guys for attending. All right, we're going to go ahead and get started to respect everybody's time. Welcome to our fourth webinar of the year in our Improving Childhood Obesity Care, a Grow Healthy series. This one is on using the Grow Healthy Obesity Prevention, Evaluation, and Treatment Toolkit. All right, next slide. So I'm going to just briefly introduce Grow Healthy for those of you who are not familiar with who we are. Grow Healthy is an evidence-based public service initiative grounded in decades of childhood obesity prevention and treatment research that has been conducted here at Pennington Biomedical Research Center. All of our resources can be found at growhealthy.org, including the toolkit that we're going to go through today. So our speaker for this webinar is Laura Boyer. She is a family nurse practitioner and project director at Metamor Institute, which is a part of Pennington Biomedical Research Center. She's been involved in the specialty care of patients with obesity for over 25 years. She's a certified bariatric nurse since 2007 and currently the co-director of the ASMBS committee for CBN exam preparation. She has a lot of expertise in the field, and I'm really excited to introduce her and let her go through our obesity toolkit. Again, you can download this toolkit for free on Grow Healthy's website, and that's growhealthy.org. Very quickly, this is the disclosure statement for Laura, our speaker, and the accreditation and credit statement from the Louisiana AAP. We're pleased to offer today's CME credit for free. And please stick around till the end of this webinar. We'll have a screen come up where you can scan the QR code, and that's how you can claim your credit for today. So I am now going to pass it over to Laura, and she's going to start our presentation for today.
Thank you, you guys. Lauren, you did a great job. I really don't have a lot of descriptions for myself, other than I have been a nurse for a very long time, and I have developed a very special passion for the advocacy of evidence-based care for the population of patients with obesity who have been treated poorly in society and even in medicine, and to promote the evidence-based care and advocate for access to care for a population who really has been told that their chronic disease is their own fault. This is a little presentation overview. I hope to stay on time, and I hope to have a little bit of time at the end to answer some questions. Basically, I'm going to follow the toolkit, and I keep my toolkit handy all the time. It's a booklet that's got lots of flagged pages, a lot of my own handwriting. When I'm taking care of patients in the exam room, this booklet was developed to be a really quick, handy dandy guide to the best practices for pediatrics and family-based care. I'm trying to figure out these arrows. I'm getting there. Yeah. Um, that's there it is. So, I want to start with the beginning of this booklet. It's based on, and it's meant to be the distillation of the AAP guidelines that were developed in 2023 for treatment and care of patients with obesity, childhood obesity. And so this whole booklet kind of distills that information. When they developed this booklet, it was meant to be kind of like a pocket guide so that providers could easily integrate these guidelines into their exam room routines. So basically, all I'm going to do is follow through this toolkit booklet and teach you how I use it and how you can integrate this care into your routine in the clinic. I would start with preparing your own team. And when I talk about your own team, I mean everybody in your office needs to be educated on the fact that obesity is a chronic disease. I'm not doing well at these slides, you guys. How did I do that? It worked a minute ago, didn't it? Okay. So the American Academy of Pediatrics developed this practice guideline, and some of the most important things to pay attention to are the 13 key action statements, and I will include that on my slides as we go along. But I really want you to know the first section of our booklet is a statement from Dr. Staiano, and I want you to just hear this. If you remember nothing else from this toolkit, know without a doubt that watchful waiting or unnecessary delay of treatment does not work, nor is it the best practice for care of our patients with childhood obesity. So it's important that we change our mindset. Patients are not going to outgrow obesity, and there's lots of evidence to tell us that. And the good news is there's lots of evidence that gives us tools to provide treatment and the best care for these patients. Here we go with the slides again. Okay. So when I prepare my team, the most important thing I start with is weight bias and stigma. You can't address obesity without talking about that. It is still prevalent in our society, in our schools, in our healthcare systems, and we as the healthcare providers need to change that. Patients become stigmatized by the way we approach obesity and weight problems. So as healthcare providers, and I'm talking like from the front desk to the back desk in a clinic or an institution, we need to educate our team and make sure that we're all addressing our own biases and delivering care with empathy, compassion, and enthusiasm for treatment of a disease. And we need to remove the shame and blame that comes with the stigma of obesity. I'm getting there. Okay, so in the booklet, there's this little table. And the first thing we need to address with our team members are how we talk about obesity. The first thing I tell everybody is we don't use the F word in our clinic. The word fat should only come up if we're talking about a cell. When we talk about people, we talk about them as a person and the fact that they have a disease. I mean, think about it. We don't call people by their diagnoses. We don't call somebody asthma or heart disease. So we shouldn't be saying the obese person or the fat person. I have patients who refer to themselves as fat, and it breaks my heart because they are not fat. They are people, they are sons and daughters, they are family members, they are They are smart. They are happy. They are, energetic, but they shouldn't be describing themselves as fat. And we shouldn't either, including ourselves. So changing our language is very important when we talk about obesity, and we need to focus on health and not just a number. I'm pushing the button. Here it is. So in our provider hub, and we need to talk about the provider hub because it's all on our website, as well as this toolkit. You can download specific PDFs to help you in your clinic, both with your staff, your patients, and their families. So this handout is about weight bias and stigma, and I would use this in my office if I were doing I recommend doing a lunch and learn or some kind of healthy breakfast break, and talk to your employees about just educating them that this is a chronic disease. I think it's important that everybody adopts these behaviors throughout the clinic. Next section in our booklet is screening and prevention. So basically, we should be screening and practicing prevention for all our patients, regardless of where they fall on that growth chart. I'm getting there. This screen is moving. There you go. So the prevention discussion begins on page 14 of your booklet. It's important that we routinely screen for things like social determinants of health, and we promote healthy diet, healthy exercise. Of course, technology use is pretty popular discussion in our care plans these days, and that it's included in all discussions with all patients, because even if your patient or their family is not discussing the actual disease of obesity, we need to be talking about prevention. Here's a list of risk factors that may be contributing to childhood overweight and obesity, and some of these are modifiable and can help us in practicing prevention. I like to share these kind of things with the community, school nurses, teachers. Some of these are very important to know that we really can't modify things like genetic factors, but we certainly can modify things like school lunches and what we're packing in our kids' lunches and what we're doing with our after school activities. Here's a Provider Hub PDF that you can download. This is a good handout for lots of different discussions. One side is actually some simple assessment questions that families can fill out and give you information before your visit. But on the back is this handout instructional page. 5210 plus 10 is a daily goal sheet of some activities that all families could implement as part of prevention. And we also use this in the treatment plans when we're talking to patients that we're providing assessment and treatment for. The next section of the booklet addresses clinical evaluation and diagnosis. So this is when you have this kind of section applies to when we have patients who are now being assessed as qualifying some of these criteria for obesity. So the key action statement number 1 is that, this is from the AAP again, that primary care providers will evaluate every child for overweight and obesity starting at age 2. Weight and BMI are indicators and need to be charted just like things like blood pressure and heart rate when we assess our patients. There's a best practices section in the book on page 19. There's also a PDF that you can download and give to your staff to make sure that everybody's using best practices for measuring height and weight. And then this little table kind of shows you the classifications for obesity. And you can see that once a patient enters that 85th to 94th percentile on their growth charts, they're considered overweight. And that is a little bit of a red flag. And then once your patients are greater than the 95th percentile, they're actually class 1 obesity criteria. So understanding that and using it as a health kind of a vital sign is a good thing to adopt into your practices. And again, there's a PDF for some of this for your staff. There is an extended growth chart available from the CDC. Excuse me. We use growth charts in our charts and even in our electronic medical records, but the normal or whatever the standard growth chart kind of maxes out at the 95th percentile. So when a child or an adolescent goes beyond that 95th percentile, you need to use a different growth chart that has an extension. And in 2022, the CDC developed these charts for us. So you can download them, print them, or put them in your electronic medical record. But once a patient gets past that 30 BMI, we really do just kind of refer to the BMI instead of the percentiles, I guess, in the practical world. So a 30 BMI is definitely in that overweight zone. And then you can see on this chart that once you get to a 38, you are well into a diagnosis of obesity, and you need to be treating and assessing in a different way. And again, this assessment should start at 2 years old. The key action statement number 4 is to treat obesity and comorbidities concurrently. And that means don't separate the obesity treatment from the comorbidity treatment. And the other thing is, I don't use the word comorbidity when I talk to families about illnesses related to obesity, because that word morbid, in my opinion, it scares people, it's negative, it insults people. I usually just say associated illnesses or conditions, or obesity related is a nice term to use when you're describing these conditions that are contributors or caused by obesity. So anyway, getting the conversation started can be sticky for some people. I recommend not using that approach on your very first initial visit with a patient and a family. You need to have some rapport and some trust and some ability to assess where they are emotionally and their understanding of health and weight and all of that growth chart stuff. So that's probably the best tip on this slide, is don't jump right into discussing weight. We all know how sensitive that can be. And for patients whose families have obesity, they've already been stigmatized. That child or that adolescent may already be stigmatized and bullied. So we have to be on their side and be advocates and make sure that we're nurturing and compassionate and not further creating stigma. So timing matters. That parent may not have bandwidth right now to talk about what she's buying at the grocery store. It may not be important because right now she might be worried about her job. She might be worried about fixing the car. She might be worried about when she can get to the grocery store. So sometimes you have to feel that patient and family position of where they are and how you can start where they are and not make them start where you are. And that takes time. So I recommend asking them if it would be okay to plan another visit to discuss their growth chart and some of the numbers that have to do with their health today and their health in the future. And that kind of takes the focus off of that weight on that scale. That number is very intimidating. And I know as a mom, I didn't want anybody to say anything about my weight, much less my kids' weight. So it can be, you need to finesse that discussion, but putting a time to focus on that is very important. So once you begin planning to treat that patient, you should try to follow up with a focused visit 2 to 4 weeks later, not 4 months later, 6 months later, because that's just delay of treatment and it's not the best practice. The key action statements 4 through 8, it begins on page 25, and there's lots and lots of information in this toolkit about assessing and screening for hypertension, disordered glucose metabolism, fatty liver disease, checking kids' cholesterol. Some of this stuff should be happening at as early as age 10. And then assessing blood pressure should actually start at 3 if you have any obesity or overweight situations. Blood pressure should be assessed at every visit. So I'm sure you're already doing a lot of this, but this kind of gives you a guide of what the best practices are and also at what point you should be referring to specialists. So the obesity focused evaluation visit is included in this toolkit. And I just want you to know that the focus of this visit is not weight. In fact, some of my favorite pediatricians say they don't even mention weight at this visit. They might mention height, or they might mention other growth curve related discussions, but it's important that you establish that trust so they'll come back. The most valuable thing is frequent contact. And if you've offended them or overwhelmed them or just hurt their feelings and made it uncomfortable, they may not come back for the rest of that treatment. And that rest of that treatment could be years. So in the evaluation, we recommend using some standardized testing, and you want to evaluate some of the obesity-related diseases, but also their mental health status, because we want to screen for eating disorders, anxiety, bullying is a very important thing to assess for. I find that some of our patients with obesity are already being homeschooled because of bullying. So it's important to be really sensitive to that. I'm trying to move this slide. There you go. So this on this is an on the in the booklet. I'm trying to realize what page it's on. But anyway, it's 2 pages of a very specific focused evaluation. And these are the components of your visit. And I'm sure that you would recognize this whole table if you're a caregiver. But I want to call your attention to the readiness to change. And it's an important part of motivational interviewing, and it's an important part to share that with other people in your team. So including that in your note is important. Like maybe, put a quote saying, mother states she can't focus on this right now. Or mother states she is also willing to participate with these changes. These are very important because you want the whole family involved that has any influence on this child's behavior changes. There's in the appendix in the back of the book on page 63 is a kind of a checklist developed by Dr. Katie Queen on a focused visit, and the checklist includes some of the things that you need to include to kind of make that a specialized visit. The other thing I wanted to mention is that we have a PDF that you can download that has billing tips for these kind of visits. So when you include this checklist in your note, you can then apply these codes for billing. And that PDF is also in our provider hub. There are risk factors that you need to assess for. One of the most important risk factors is genetic risk factors. Sometimes people don't even know that there are genetic risk factors. And sometimes we had one child that we diagnosed with the genetic phenotype, and then we tested his mom, and she didn't know she had the genetic marker either. So it is provided free, and this website called uncoveringrareobesity.com will cover the cost. And I would recommend that if you're going to really practice in a focused way, that you reach out to them and have at least one kit on your shelf in case you want to grab it and do that test right there in the exam room. Individual level risk factors associated with childhood obesity. This is a table on page 24. You might want to use this also in your notes to say that you've addressed these in a organized fashion. And I want to call your attention to the bottom section of usage of weight promoting medications. That's important to note in your chart that there are certain medications that we can choose and certain medications that you have to take this medication, like anti-seizure medicines and things like that. But knowing that they influence weight gain and maybe inability to lose weight is important when you're doing this obesity focused evaluation of children. So this table is on page 24 in this handy dandy toolkit. I am slow at moving these slides. I'm sorry. I just keep watching. Okay. The specific review of systems is also something that you may want to just copy and download. You may want to use this for a checklist for families to fill out. Sometimes we already have those embedded in our EMR kind of review of systems, but you can certainly tweak it to include some of these things. And one thing, again, that's on this list is some of the genetic related conditions that like Prader-Willi, some of the GI conditions and orthopedic conditions are something we also need to address in this assessment. Sometimes patients come to us for obesity treatment because the orthopedic doctor sent them. They're already having knee issues and maybe their conditioning, their ability for exertion is not like their classmates. The next section is moving on to treatment for childhood obesity. So I must have clicked it twice. So once we get to this section, this really addresses that key action statement 9, the comprehensive treatment of childhood obesity. And I want to emphasize the word comprehensive because if you're a sole provider, you don't have a lot of multidisciplinary people in your clinic, but it's important that you understand that you don't have to do it all. You can do some of it, but you may need to refer to community providers, either utilizing a pediatric obesity specialist. There are dietitians, there are health coaches, and you also want to probably know if there's a surgery team in your region to refer to for patients who may be interested in that treatment. But the most important thing is to enable and deploy the team and the tools that you have. And we are trying really hard to supply you with those tools. So if you come across tools that you wish you had, please communicate with us. We would love to grow that provider hub and supply the whole community with tools that are not just informative, but that get used. So don't hesitate to share these tools with your colleagues. We love when our stuff travels amongst colleagues. The next key action statement is number 10, and it talks about using motivational interviewing. And on page 40, there's a whole lot of information, but let me tell you, there's so much information on motivational interviewing that it's a complete afternoon course if you're really interested. And I highly recommend it. So the AAP does have a link to kind of talk about how to adopt motivational interviewing when you're taking care of children with obesity. A lot of it incorporates just, of course, person first language, but ways to approach subjects that may not be easy, and also to give the patient and the family members, the caregivers, control about which goals they want to work on. And as healthcare providers, we don't often make time for doing motivational interviewing well. I'm guilty of that because we're very pressed for time. And this is another reason that I say that this needs to be a separate appointment with this focus on this disease and the health that's related to it, because it takes time to build that relationship and be a coach and not just talk at them. The one comment we just got from a clinic we visited, I think it was this week. Yeah. The patient's feedback was that when they meet with nutrition people or, social workers to talk about treatment, it's overwhelming. The amount of information being dumped on this patient and family can be very overwhelming. And we as healthcare providers need to be very cognizant of that, because most people, when they're overwhelmed, just give up or shut down. Or when I'm overwhelmed, I emotionally eat. So that can be one reason they don't return to us. In our provider hub, there's 5 handouts that you can use and share with your colleagues and staff that address motivational interviewing and how to communicate better with your patients and families. So on page 39, there's a little guide for addressing weight goals. And unlike adults, we don't always focus on losing weight because remember, kids are still growing. So they have the advantage of growing tall without worrying about weight. Adults are different when they have to get on that scale. They know they're not going to grow any taller. From ages 2 to 18, when the BMI is below the 85th percentile, you always promote counseling for obesity prevention, and you show them where they're at on the growth curve and what should be expected as they continue to grow. And then there's a chart that addresses weight goals, and you'll see that when their BMI is and their percentiles are lower than 95, it's okay to just maintain that growth curve. We're not really doing any aggressive weight loss, but to maintain that growth curve will take intervention. So it's not like we're not doing anything. That intensive health, behavioral, and lifestyle therapy is still very important, and preventive measures. And you'll notice on this chart, motivational interviewing and the health and lifestyle therapy is kind of continues through all the options and all the weight categories. Once a patient is in that 95th to 99th percentile, we're looking to gain some ground on weight loss. But we don't want to encourage excessive weight loss because honestly, that can trigger some poor eating behaviors. It can also be a little bit, it's a little bit overwhelming, and then patients start obsessing about the number on the scale instead of health. And we need to be part of that therapeutic discussion that it's not about weight, it's about health. And all of society focuses on weight. Look at any magazine section. It's all about weight loss and numbers. So it's very intense therapy to change that focus. And sometimes it's therapy on the family. Key action statement number 11 talks a lot more in detail about the intensive health, behavior, and lifestyle treatment. This is evidence-based. The research has been conducted at Pennington and with many centers around the country, and it's a very well thought out plan of intervention, and it needs to be taught. Oh, great. I just got a notice that I need to update my computer. I'm sorry. But anyway, IHBLT is we have this little graph on the page, is that it talks about anybody after age 6 should be offered this intensive health, behavior, and lifestyle therapy. And it involves 3 to 12-month commitment with a recommended total of 26 contact hours. And they don't all have to be with the pediatrician. They need to be with the multidisciplinary team. They can be with nutritionists. They can be with physical activity coaches. It can be telehealth. But the most important thing is frequent contact and building a relationship. And this is the best practice with the best results. So aiming for 26 hours of contact is ideal, but aiming for any contact is really where some people have to start. The Provider Hub helps us with some handouts. So you'll see where we discuss setting SMART goals, and those are very specifically lined up to be based on what the patient feels they can do and are willing to do. So you can use this to give to the patient, put it in the chart so that all the caregivers know what kind of SMART goals are being worked on. It's important to share this information with the care team. And this is one of those downloadable PDFs that we would love you to share with all of your colleagues and tell them where they can get more. So the recommended treatment, here's kind of an example of how you would set up these visits ideally. It's 26 hours over 3 to 12 months. And if it takes you 24 months, I mean, the most important thing is that you continue to follow up with the patient and their families. Medications is the other piece of the treatment triangle, and we talk about this in the toolkit on page 44. It's a key action statement that primary healthcare providers should offer adolescents 12 years and older with obesity weight loss therapy that includes medication. Now, they may not want it, but they need to know that it's available, and we need to know how to offer it. And if you don't feel comfortable prescribing some of these medications, you really have options. You can learn how, or you can refer them to somebody who does. There's pediatric obesity medication experts at your convenience. You can reach out to them. If you would like information on that, you can always email me. But it's important to remember that they don't have to fail the lifestyle intervention to then go on to medication. If a patient is in that obesity category, and especially if they are already positive, showing positive signs of, high blood pressure and the other metabolic diseases, you need to be more aggressive and offer lifestyle intervention plus medications. And this is a list of the currently available medications that we use. Most patients at the age of 12 qualify for use of these medications. But I bet we're going to have a webinar completely devoted to the use of medications, so stay tuned. The metabolic and bariatric surgery is also a treatment option. We offer this treatment for patients usually at 13 years and above. Most importantly, if they've started developing really long chronic conditions that will affect their entire lives, and that's called diabetes, fatty liver, things like hypertension. This can lead to adults with terrible chronic diseases. And if we have a chance to intervene in childhood, I mean, we're not responsible if we don't try. So class 2 obesity and class 3 obesity for patients is pretty much the criteria to discuss bariatric surgery. And if you need to refer to a bariatric surgeon in your area, there's a website on ASMBS. It's the Organization for Bariatric Surgery. Or if you just need more information, you can always email me if you would like me to reach out and help you find a bariatric surgeon in your area that is qualified to operate on children and adolescents. The most important thing is that you look for accreditation and you look for experience. And then we give the patient back to the pediatrician, but we reassure everybody that we follow up. Bariatric surgery requires follow-up and supplementation. We want to follow them very closely with lab work. They need to take vitamins. They need to know about protein. And of course, they always need to have that healthy lifestyle coaching involved. You also may need some mental health coaching. So evaluating the patients in an ongoing way, if they've had bariatric surgery, is pretty important. Please reach out to your community providers, and you can always email me and I will help you connect with them. In the Appendix 2, there is a FAQ kind of list of questions that providers may have when they want to talk about bariatric surgery, but it's on page 64 and it's ready when you need it in the toolkit. There is on our website in the Provider Hub, our just last webinar, the one in July, was conducted by Dr. Noor Hanipa, who is a bariatric surgeon, and she works here at Pennington, and she covers bariatric surgery and the fact that it's safe and the implications and complications and all those important medical discussions. So I encourage you to go to our Provider Hub and view that past webinar. Included in this booklet is at the back pages is a list of resources, and it's a big list, and it probably will need to be updated within the next year, but it's state specific resources, and it has to do with things that you might want to do for handouts or talks on your own. You also may want to access this for behavioral health tips. Sometimes we're not always equipped in our individual offices to provide behavioral health that's specific to obesity, but resources are important to reach out. I'm a very big proponent of telehealth. And although I love to have my hands on my patient because of physical assessment, I think telehealth is the best thing that's happened to us since COVID. What else do we have? Oh, thank you. Did I finish on time?
Yeah, you're actually a little bit early, so I want to open the floor to questions for anybody. If anybody has any questions for Laura, you can drop it in the chat. You can also drop it in the Q&A section on Zoom, and I can make sure that Laura gets your questions answered. But while we're waiting for some questions to come in, Laura, I wanted to ask if you could maybe give a little more details about Metamor in general to our participants and how you come into play.
So the Metamor Institute is a clinic within the Pennington campus here on Perkins Road in Baton Rouge, and we're a comprehensive obesity treatment clinic. We see patients, actually, we see any patients, but of all ages, but more importantly, patients who are interested in obesity treatment and surgery. So our staff consists of all the disciplines, dietitians, surgeons, obesity medicine specialists. We also have on staff a pediatric obesity specialist, Dr. Katie Queen, and we are dedicated to the comprehensive care of patients, and it needs to be evidence-based. We don't promote fad diets. We don't promote crazy exercise. We do promote exercise, and we do promote good nutrition, and we offer all the medications and all the treatments available. I, as a nurse practitioner, see patients, and it really is my passion to promote health and not weight stigma. And I do a lot of work in the community and with my colleagues to spread the word about weight bias and stigma. There's a website called Obesity Action Coalition, and there's a lot of good videos and there's a lot of good information for lay people to learn more about how to fight and advocate for adequate care and appropriate care for our patients. Any other questions?
Thank you, Laura. I am monitoring the chat right now, and I don't see any questions at the moment. Please feel free to type your questions. Additionally, if you guys open up the chat, we have provided the link to our provider hub on the Grow Healthy website. Additionally, we've provided the direct link for our toolkit. So if you haven't had a chance to download it, open it up, look through it, get yourself familiar with a lot of the things that Laura talked about. Yeah.
Since I'm ahead of myself, let me talk about this a little bit more. We really do advocate meeting patients where they are. And that means also meeting providers where they are. So if you're in a practice that doesn't have a staff dietitian or a staff social worker, which is pretty common right now, knowing where to go for referral is important, but also maybe understanding that you may have people on your team who are ready to do this and help. You don't have to have a license for nutrition to talk to patients about some of the important changes that we can do with our grocery shopping and stuff like fruit juice isn't a good idea for lunches, and those are a little bit less intimidating. And it's important both for our own health as coworkers and for our patients that we practice what we preach. So I really feel like we need to support each other in this fight for health and destigmatize the stuff we bring to our offices and share for treats in the kitchen. Don't set your coworkers up for failure, and preach what you preach and walk the walk, because I really think that bias and stigma starts with healthcare providers. We ourselves are hypercritical of our own bodies and maybe hypercritical of each other. So we need to be more kind, more forgiving, less judgmental, just in general. And one of my passions is to plug into the advocacy that goes on when